Ladies and gentlemen, good morning and welcome for our final webinar. It's called the DiaBeat webinar series, and this is our 10th webinar and the last for this year. Remember that our diabetes challenge is coming to an end, perhaps around November 14th, 15th, and 16th. That's when we decide the winners of our diabetes challenge. And the remarkable finding that we have had from our diabetes challenges over the years is that very often individuals, and I don't mean one or two, we have 5,000 participants. So, I mean, several hundred of these participants have an HbA1c in the range of 8 and above. And remarkably, I use the word with emphasis, remarkably, we have discovered that at the end of our 3-month challenge, they are down to 5.8 and in that area. And by any standards, that is remarkable. But ladies and gentlemen, our last webinar, and as the saying goes, you always save the best for last. Our discussion today is diabetes and nephrology. That would be kidney care. But I do not use the sentence saving the best for last lightly. My friend, colleague, and my respected colleague and friend, Dr.Ravi Andrews from Apollo Hospital is our speaker today, and he is voted by his colleagues as one of the best nephrologists in AP and Telangana, and he is amongst the best in India. He is one of the 3 nephrologists in India to perform a successful 3rd renal transplant on the same patient in 2012, and the first nephrologist in AP and Telangana to perform swap kidney transplants. Now, I can't for the love of me imagine how Dr. Ravi does these things, because I know Dr. Ravi as an all-round personality. He is an active musician. He is a theater actor. He is a fitness fiend. He is an avid academic. But that really is the other side of Dr. Ravi's personality. Dr. Ravi is with the Apollo hospitals in Hyderabad. He completed his MBBS from CMC Vellore, a prestigious institution, and then went on to do his DNB in general medicine, and put the icing on the cake, did his next DNB in nephrology from Apollo Hospitals, Hyderabad. I've already mentioned that he has 30 years of clinical experience, and I notice that he has several publications, and I have no choice but to read from this paper here, because what he has written about is far too complex for my comprehension. And it says over here that he has several papers, and the one that has caught my attention is the percutaneous transluminal renal angioplasty with stent for the treatment of transplant renal artery stenosis. The heading by itself is an article. Can you imagine? Dr. Ravi does complex things like this. But I recall not more than a few years back reading an article by Dr. Ravi, which he wrote about himself. Friends, you need to know that Dr. Ravi is a COVID survivor and a COVID warrior. He has written an extremely emotional, I'm sure it is scientific in many ways, but an extremely emotional article. He was one of the early individuals to get COVID, and at that time, the whole world was searching for solutions. And I imagine Dr. Ravi found his own. And he survived and is with us here today to present this exciting discussion. I've had the good fortune of going through Dr. Ravi's slides in advance, and I noticed at the bottom of his CV, it mentions that he speaks in several languages: English, Hindi, Telugu, Oriya, Marathi, Tamil, Gujarati, and French. Friends, my humble request to Dr. Ravi is to kindly talk to us in English, in simple English that we all will understand. Dr. Ravi, I hand it over to you, sir.
Thank you very much, Professor Kennedy, for that wonderful introduction. Let me tell you, I am very impressed with myself after listening to your introduction. And welcome to everybody for the DiaBeat seminar, Beat Diabetes Challenge. And it's my pleasure and honor to talk to you about diabetic kidney disease. Now, just give me a second while I share my slides. Just a second.
Yes, Doc. Perfect.
Yes. So in today's 30-minute talk, I'm going to discuss about diabetes and renal health. And the focus will really be on prevention rather than the management. But of course, the first few slides, we will talk about the management of diabetic kidney disease, especially with regards to the technical aspects like medications. And then we will talk about what we can actually do at ground zero level to prevent and manage the complications of diabetes and diabetic kidney disease. Now, I'm sure we all know that diabetes and diabetic kidney disease is huge. It's a huge, huge burden. It's even, if you talk about hugeness, it's even huger than the the World Cup that is going on, the Cricket World Cup that's going on in India right now. It's even bigger than that. Now, if you look at statistics, and statistics sometimes are pretty close to facts, over 500 million people have diabetes, 10%. So every 1 in 10 people that you meet will have diabetes. Kidney disease is even worse. 16% of the Homo sapiens species have got kidney disease. That means 1 in 6 people have got some kind of kidney disease or the other. And among all the kidney diseases, if you look at the causes, diabetes is the commonest cause, making up nearly 50% of all kidney diseases. Now, why are we worried about disease? We're worried about disease because ultimately it leads to problems and it finally leads to death. And if you look at the top 10 causes of death worldwide nowadays, kidney disease is among them. The other ones being heart disease, so heart attacks, strokes, cerebrovascular strokes or brain strokes, cancers, lung diseases, and diabetes itself is among the 10 top causes of death all over the world. So both diabetes and kidney disease are both in the top 10. So you can imagine the impact, the immense health burden that diabetes and kidney disease have on the human species. To put this into perspective, to understand how devastating diabetic kidney disease is, or any kind of kidney disease is, if you take a 20-year-old person with kidney disease, compare him and look at the longevity of him as compared to a healthy 80-year-old person with no other diseases. This 20-year-old with kidney disease is 100 times more likely to die, statistically. Apart from that, diabetic kidney disease is so common that among type 1 diabetes, that means those who've been detected at an early age are insulin dependent, 30%, 1/3 of them are likely to get kidney disease because of diabetes. And among those who've been detected at a later age, type 2 diabetics who can initially manage with oral hypoglycemic agents and later require insulin, nearly 40% of them are likely to get diabetic kidney disease. Now, unfortunately, diabetic kidney disease, those who are going to get diabetic kidney disease, it's genetically predetermined. So there is a genetic tendency with an environmental trigger or insult. So those who are prone to getting diabetic kidney disease will probably have some environmental trigger which will make them get full-blown diabetic kidney disease. And the environmental triggers that we're talking about are poor diet, stress, and poor lifestyle management. So, and this towards the end of this talk is what I'm going to focus on, because ultimately it's the lifestyle that's going
Dr. Ravi, can you hear us? Because now you are stuck. I think we lost connection with Dr. Ravi. Yeah. Yes,
Dr.
sir.
Riku, I'm back. I'm so sorry. I'm so sorry.
No problem. No problem. No problem.
I am screen
That's the
sharing.
main hurdle between the two countries when we are traveling through digital world. No issue. No issue. Continue, sir.
So I'm just screen sharing. Are you able to see my screen, please?
No, doc. Screen we can see. Yeah. Perfect. Slideshow is there.
Okay, great. Am I audible now?
Perfect. All audio
Yes, sir.
visual clear.
Great. So let's go ahead. Now, like I said, nowadays, the thrust of clinical medicine is more towards non-communicable diseases. Diseases like heart disease, strokes, cancers, diabetes, blood pressure. 20 years ago, most people used to die of infectious diseases, but nowadays it's non-communicable diseases. And the importance of this clinical change in direction is we can do something about non-communicable diseases in the sense lifestyle. These are mostly lifestyle modifications, and lifestyle modifications can definitely make a difference. So coming back to diabetic kidney disease, the most important thing, I know this is a kind of a busy slide, so I'll try and make it simple for you. The most important thing to understand a disease and treat it and solve it or prevent it or reduce the complications is to understand what we call the lifestyle of the disease, to understand the natural progression of the disease. And to do this, as clinicians, we use 4 parameters. One is the time or the duration of diabetes. 2 is the blood pressure. 3 is the urine protein excretion, because this is one of the first signs of diabetic kidney disease. And 4, something called the GFR, but to simplify it, this is very complicated. We do something called the serum creatinine. So these 4 parameters, the time, the blood pressure, the protein excretion, and the creatinine, will help us understand the progress of diabetic kidney disease or diabetic nephropathy. So stage 1 is where everything is normal, and this is present at the time of diagnosis of diabetes itself. And here the blood pressure will be normal, urine protein mostly is normal, the creatinine is normal. Stage 2 is a silent stage. Again, everything will be more or less normal, so you cannot pick up diabetic kidney disease at this stage. The third stage is the crucial one, because this develops 6 to 15 years after onset of diabetes. It presents with slightly increased blood pressure. So when you monitor the blood pressure, if it's increasing and there's 10 years of diabetes, that you know that this person is impending towards diabetic kidney disease. There is a minimal amount of protein loss in the urine, just 30 to 300 milligrams per day, and the creatinine starts to rise. If the normal creatinine is taken as 1, it starts going up above that. So any of these are stage 3. It's called the stage of microalbuminuria. And this stage is crucial, because if you can pick this up at this stage, you can reverse diabetic kidney disease. You can cure diabetic kidney disease if you can discover the person at this stage. So it's crucial to, when a person is a known diabetic, crucial to start monitoring these 4 things: the duration of diabetes, blood pressure, protein, and creatinine. These are all simple tests which can be done in a basic lab or at the bedside. From stage 4 onwards, when the protein levels start going up and the blood pressure starts going up and the creatinine starts going up further, there is nothing much we can do, but we can limit the damage. So we can slow down the progression and prevent them from going into stage 4, which is the frank end stage renal disease. So this stage 3, is a crucial one. If you pick it up there, and there is treatment for that, apart from treatment, lifestyle modifications will also make an impact here. You can prevent them from going to stage 4. Even if they do go to stage 4 for whatever reason, you can still slow down the progression to stage 5. Like I said, the thrust of clinical medicine today is prevention rather than treatment. And to prevent anything, there are 5 levels of prevention. Whether it's diabetes, diabetic kidney disease, or any disease, the 5 levels being, 1 being the primordial or the initial, the beginning, the nascent level. Then there is a primary, a secondary, a tertiary, and a quaternary. I'm going to discuss each of these in detail, because this is what is important. This is what the RUC Diabetes channel is, challenge is all about. It's about preventing disease. It's preventive medicine that we're talking about, not therapeutic or treatment or clinical medicine. So primordial is prevention. We're talking about prevention of diabetic kidney disease, but this could apply to any kidney disease or any disease for that matter. So the first stage of prevention is prevention of the disease itself. So if you want to prevent diabetic kidney disease, you try and prevent diabetes itself. And how can we do that? 1, educate the general public, and educate them in the sense that everybody at some point in time should have a blood sugar testing. Because diabetes is a silent disease, and at any point, it could be in schools, or it could be in universities, anywhere, every person should have a diabetic test, and it's a simple blood sugar testing, fasting, or a random, or a postprandial, 2-hour postprandial blood sugar. So educate the public that they should have these tests. They should get a BP checked at some point in time. They should have a routine urine tested some point in time, and if possible, a creatinine as well. So these 3 or 4 simple tests would help identify the problem early. And surveillance, go through the public, tell them, and identify those who are at risk for getting diabetes or diabetic kidney disease. And usually this would be parents who have got diabetes. The children are definitely at a higher risk for getting diabetes. Not only that, those children who are obese, or those children who don't do any physical activity, those
Sorry, there are glitches in the connectivity. I think Dr. Ravi is again stuck. Please bear with us. Yes, Doc. We can see you now.
I'm back again. I'm so sorry.
No issue, no issue.
I'm sharing again.
Yeah, sure.
Can you see my screen?
Yes, Doc. Perfect.
Yes, so we are talking about children who are obese and who eat a lot of junk food, not very careful about their diet control. They are again at risk, and we need to surveil them and identify them. And finally, as part of the primordial prevention is health promotion, where we actually tell the patients who are at risk how they have to do it, how they need to change their lifestyle, and how they need to make modifications to prevent diabetes itself. The primary prevention would be, once you've already got diabetes, how do you prevent a diabetic from getting diabetic kidney disease? And the formula is very simple. You need to have tight blood sugar control, and the recommendations by all nephrologists are very clear. Keep the fasting blood sugar below 120, keep the post meal below 160, and the HbA1c below 7%. Keep the blood pressure very tightly controlled. This is for most people. Keep the BP below 130/80. Of course, for very elderly patients, we relax it a little bit, and we even allow a systolic blood pressure of 150. But for most people, for more than 90% of diabetics, keep the blood pressure below 130/80. The lifestyle changes are crucial. Diet, exercise, your behavior, your sleep patterns, how you manage to manage the stress in your life, how do you do regular checkups, how do you control your weight. These are all things which play a major role in the primary prevention of diabetic kidney disease among diabetics. The investigations you need to do would be a yearly creatinine, sodium, potassium, etc., the electrolytes, a urine examination, and urine microalbumin every year. This is very simple to do. It can be done at any lab, and once a year testing in a diabetic, at least once a year testing in a diabetic is crucial. Secondary prevention would be, once you've already got diabetes, you've got diabetic kidney disease, how do you prevent the complications? And the complications most commonly are strokes, heart attacks, gangrene, and leg infections because of poor control of blood sugars, worsening kidney disease, and diabetic neuropathy, where the legs and arms, they get all tingling and numbness and pain. Now, when you have somebody who's got an early diabetic kidney disease, if, like I said, in stage 3, the microalbumin stage, if you can identify it, you can reverse it. If it goes to stage 4, you can prevent worsening or progression of the diabetic kidney disease. If not prevent, at least slow it down. So this would be the secondary prevention, and this is based, the bedrock of secondary prevention is early diagnosis. And early diagnosis depends on early identification of the signs and symptoms, and also labs. Now, when we talk of symptoms, we're talking about what the patient tells us, what the patient feels, and signs are what the physician elicits from the patient. And I will go from head to toe to tell you about the different symptoms and signs of early diabetic kidney disease. So if we start with the head, with the eyes, many patients complain that they have swelling swelling around the eyes when they wake up in the morning. Many a time the patient's partner or the one or parent tells us that when they wake up in the morning, there's a swelling, there's a puffiness around the eyes. Many diabetic kidney disease patients have pallor when you look at the eyes, anemia, low hemoglobin. We can also look inside the eyes with the fundus, which is a basic simple test which can be done in the clinic. And if there is evidence of something called diabetic eye disease or diabetic retinopathy, that is a precursor of diabetic kidney disease. So if you start from the head, the eyes will tell you about the pallor, will tell you about puffiness, and if you can check the fundus, it will tell you about early diabetic changes in the eyes. If you go further down at the chest level, many patients with diabetic kidney disease complain of breathlessness. Sometimes they have chest pain. Some people have difficulty in swallowing. Some people have loss of appetite, bloating in the abdomen, constipation, or diarrhea. These are all features of diabetes of any kidney disease. Lower down, urinary bladder. People have either decreased urine output or increased urine output. And by increased urine output, we're talking about more than 3 liters per day of urine. And by decreased, I'm talking about less than 500 ml of urine per day. So anybody with impending kidney disease will have some changes in the urine output. Of course, now we need to remember that this urine output is dependent on the fluid that you take. And the recommended fluid intake per day is 2 to 3 liters. And with 2 to 3 liters, if you're passing more than 3 liters of urine, that means you're passing too much urine. If you're passing less than 500 ml of urine or less than half a liter, you're passing too less. And this means that you're likely to have some kind of kidney disease. Further down, if your feet are swollen, again, this is a suggestion that you might have kidney disease. So quickly, the symptoms and signs of any kind of kidney disease, and specifically for diabetic kidney disease: puffiness of the face, low hemoglobin, retinopathy in the eyes, breathlessness, nausea, vomiting, loss of appetite, abdominal bloating, decreased urine output or increased urine output, and swelling of the feet. The labs that we do, we check, like I said before, the creatinine, urine microalbumin, and in selected cases, an ultrasound of the kidneys. How do we treat and how do we do a secondary prevention of the complications once diabetic kidney disease has set in? There are specific medications. We know there are a whole lot of medicines called oral hypoglycemic agents which can be used. And today, in today's age, the US FDA has approved this particular drug called dapagliflozin, which is the drug of choice in early diabetic kidney disease. And preferably, you want to give insulin. There are certain antihypertensives also which help to keep the blood pressure low and also to keep the urinary protein under check. And a new drug which has recently been approved by the US FDA called Renal is also useful in the prevention of the complications of diabetic kidney disease. But this part, I would suggest that you leave it to your physician to guide you. Regular follow-up is also important so that you understand in which direction you're going. So regular follow-ups of the creatinine, the urine, the albumin, and the ultrasounds. The tertiary prevention is damage limitation. When you've already got all these complications or one of these complications of either a stroke or advanced kidney disease, or you had a heart attack or you have gangrene, how do you prevent further disability or death? And that is what tertiary care is talking about. And finally, the quaternary prevention would be to avoid unnecessary medication. It's so easy for all of us. If you have a cough, cold, or a fever, just to pop a pill, take an antibiotic, take a painkiller. Don't do that. And many people try herbal medicines. Please avoid unnecessary antibiotics in herbal medicines. These are the stages of chronic kidney disease. I will quickly go through them. I'll make it very simple for you. There are 5 stages. Stage 1 is a creatinine of 1, stage 2, creatinine of 2, stage 3, creatinine 3, 4, and finally, if the creatinine is more than 5, it's stage 5. There's only one point I want to make about this staging. This stage 1 looks weird, doesn't it? It looks like creatinine of 1, so it's normal. Why would you call it stage 1 of chronic kidney disease? So this is primarily patients, sometimes they are born with just one kidney, or they have urinary stones or kidney stones. These patients will have normal creatinine, but you know that they have some underlying kidney disease. The point of this staging and categorizing people in stage 1 is early identification. This is early identification of a person who is at risk. So early identification of at-risk population for developing CKD. That's why this stage has been placed. Now, a dietitian is probably a better person to tell you about detailed diet in kidney disease. I will try and make it as simple and easy to use as possible. So the first thing which I've been saying, and I'm going to keep on saying till the end of this lecture, is do not use herbal supplements. Do not use herbal medicines, because herbal medicines are well known to cause worsening of kidney disease. And the diet that you're going to take is based on whether you have the early stage diabetic kidney disease or the late or the dialysis requirement stage. So you can divide them into just basically 2 stages. So stage 1, 2, 3, 4 of chronic kidney disease would be the early stage, and stage 5 would be the dialysis stage. This is as regards diet is concerned. So the basics for any diet, you need to keep carbs at around 60%, protein 30, and fats 10. But in those who have got diabetic kidney disease, you need to reduce the protein intake. So get most of the energy from carbohydrates, reduce the protein to less than 1 gram per kg per day. Polyunsaturated fatty acids are preferred, preferably plant protein rather than animal protein, because animal protein, apart from all the nitrogenous waste products, also has phosphorus and potassium, which is dangerous in those who've got kidney disease. Mediterranean diet with a lot of fruits and veggies and legumes is ideal. And you also need to take some micronutrient supplements like manganese, magnesium, and a few other iron and other micronutrients. Calcium and vitamin D are required because those who have kidney disease cannot process vitamin D properly, and their calcium levels are usually low. A low salt diet, 6 grams per salt will give you about 2.4 grams of sodium. So common salt, sodium chloride, 6 grams. If to make it simple, in our normal diet, we take about 12 to 15 grams. So just make it 50% of that, of your normal salt intake. And this, I think, applies to anybody rather than just diabetic kidney disease or diabetes or hypertension. I think all of us as individuals should have less salt. We tend to eat more salt than we require, and salt is there in ubiquitous amounts in all over, in many things. Surprisingly, even bakery items like biscuits would have a lot of salt in them. Anything which is processed has salt. Ketchup has salt, butter. So all these things which are kept in the fridge, most of them will have salt because salt is used as a preservative. So try and cut down on all this. Of course, papads, pickles, junk food, French fries, these all things need to be minimized as much as possible. Have less potassium, and the dietary sources of high potassium include fruit juice, coconut water, bananas, kiwis, some citrus fruits, and watermelon. And among the vegetables, potatoes and tomatoes have more potassium. So be very careful about them if you have diabetic kidney disease. And phosphorus comes from red meat or animal protein and milk and milk products. That doesn't mean that you should stop or completely make milk and milk products zero, but be judicious and not have too much of that. And people talk about these fad diets. Absolutely no. These diets like the Atkins diets, the whatever, the intermittent fasting, the keto diet, in those who've got diabetic kidney disease is an absolute no-no. And also these fad diets are not sustainable over a long run. Not only are they dangerous, they're also not sustainable. Those who've got late stage, that means dialysis requiring diabetic kidney disease, we can increase the protein intake to much more. You can go up to 1 to 1.2 gram per kg per day. And animal protein is fine. Again, no herbal supplements. this is something which is going to be very close to Dr. Kennedy's heart about exercise. And exercise is the key to lifestyle modification, and it does so many things. A 45-minute session of exercise on a daily basis can reduce your BP by 10 millimeters of mercury. It can reduce your sugar by 20 milligram per DL of sugar. It controls your weight. It improves your sleep pattern. It reduces the stress and reduces all the lifestyle problems that you could have because of bad lifestyle. It gives endorphins and enkephalins, reduces stress, like I said, improves your heart function, because if you have diabetic kidney disease, your heart is likely to give you trouble. And doing exercise on a regular basis will keep your heart ticking well. Increases muscle strength, because there's always a risk of a stroke in somebody who's got diabetes or diabetic kidney disease. If you already have good muscle strength, then you will be able to tide over a crisis of a stroke. I'm looking at the worst case scenario here. It reduces osteoporosis. Now, some people complain that because of exercise, I'm having joint pains, my bones are weak and all that. But for every one person who gets joint pains because of exercise, I can tell you 100 people who get osteoporosis because of lack of exercise. So that is crucial. It surprisingly, exercise also increases your immunity by upgrading the T cells. There's something called a T cell receptor, and this helps prevent infections. If you notice, those who died during COVID, most of them were either unfit or had some kind of medical problem. So if you have a good fitness level before itself, you can fight off infections better. There's a lot of talk now about exercise being useful in the prevention of certain cancers like CA bladder, CA prostate, CA stomach, carcinoma of the uterus, all these, and cervix, all these the risk can be reduced by doing exercise. And this is science. This is scientifically proven. There are also certain hormones called ghrelin and leptin. We've heard of them. So these are also downgraded or upgraded based on your exercise. So leptin is something which suppresses your appetite, and it is upgraded during exercise. Ghrelin is something which increases your appetite. It is downgraded during exercise. So you have a double action there. How much is recommended? At least 150 minutes of moderate intensity exercise per week. And the operative word here is at least. If you can do more, please do more. And science has shown that the more exercise, the better it is. And always, when you talk of moderate intensity exercise, you're talking about doing exercise without having to hold or without being able to hold a conversation with somebody else. If you're on the treadmill, you're walking and you're on your phone and you can talk and you're not breathing fast, you're not doing proper exercise. It's not going to work. If you're on the treadmill and your buddy is there on the next treadmill and you're talking to him, it's not the proper exercise. It's not proper intensity. So at least 150 minutes. We're talking about 30 minutes every day, and it should be a good intensity exercise. And always couple your exercise, your cardio, with strength training, because that also helps reduce your metabolic rate. And if you want to lose weight, the only way to do it is couple cardio with strength training as well as diet. And this is something which a lot of youngsters are misusing now. Protein supplements in the gym, they take creatine or whey protein or
Please bear with us. Please bear with us. It's taking a little more time.
Dr. Wilku, I'm back.
Yes, Doc. Welcome back.
Oh, I wonder how many more times you're going to say welcome back today.
No issue. No issue. No issue. It's very interesting. People have started asking.
I'm sharing the screen again.
Yeah, sure. Perfect.
So, yes. So, like I said, no protein supplements, because anything which comes off a shelf is dangerous, and it has some kind of preservatives in it. And most of the time, these are salt preservatives, and salt can worsen or make your blood pressure or cause other problems, especially if you have some kind of kidney disease. Go natural. If you want to increase your protein supplement, have animal protein or veg protein. Anything which is perishable is usually safe. So just to summarize my whole presentation, we need to know that nearly half of diabetics can get some kind of kidney disease. It's crucial to make an early diagnosis so that you can reverse it in the early stages itself. And stage 3 diabetic kidney disease, where the urine protein is just between 30 to 300 milligram per day, or the stage of microalbuminuria, is a stage, if you can identify it at that stage, you can reverse diabetic kidney disease. Even in the later stages, even if the creatinine starts going up, the urine protein is increasing, you can still limit the damage by slowing down the progression by certain medications and lifestyle changes. And the crucial things for prevention of diabetic kidney disease or slowing it down are blood sugar control, BP control, and weight control. And these are all things that you can do with lifestyle changes. So medications, which are really important, but diet and exercise play a really major role in the management of diabetic kidney disease. And that's what the RUC DiaBeat challenge is all about. And it's not just one person who needs to take care of a patient who has got impending diabetic kidney disease. We need to involve an endocrinologist to keep the sugars under control, a kidney doctor, a foot surgeon, because infections are a very common aspect of any diabetic kidney disease. And we also need to involve a dietitian, a physiotherapist, and a counselor to keep a patient psychologically going and to motivate them to keep continuing to maintain their blood sugars, blood pressure, and maintain the lifestyle changes that they're going to be doing. Thank you all very, very much for listening to me. And I would like to hand over the whole thing now to Dr. Wilco and Professor Kennedy to take you through the rest of the session. And I will be very, very happy, and it will be an honor and privilege to answer any questions that you have. And again, my sincere sorry for not being able to do this in one extended session. I'm so sorry for all those technical glitches. Thank you.
Dr. Ravi, we have had the good fortune of welcoming you 3 times in today's session. That was a great privilege and an honor. And you, on every occasion that you came back, you said sorry. Love means never having to say sorry. And I mention this in the context of when you were having difficulty with streaming your slides, a remark beeped up on the screen which says, worth the wait, meaning that your audience was willing to wait any length of time to have to listen to your words of wisdom. And I have to tell you, Dr. Ravi, when I saw your slides, I thought they were frighteningly complex. But your presentation was delightfully simple. And that is the sign of true knowledge. Keeping it simple, that is the sign of true knowledge. Thank you so much, Dr. Ravi. Thank you so much. And I request Dr. Wilku now to ask the questions that our audience might have presented to him. Dr. W.
Thank you, Professor. First of all, thank you, Dr. Ravi, for a wonderful presentation. It was really, like Professor said, it was technical, little-hearted, but it was well explained in easy words. Everyone can understand. And most of our friends and the participants are from the medical professionals, so they have their own views and thoughts also. They shared with that. That's very great. First question I will take from Mr. Piyush. Even I was wondering when you spoke about puffiness of eyes, and immediately within few minutes he has asked this question. Piyush is asking, my mother is diabetic on medication. She frequently have puffy eyes and swelling of both feet. Is it something serious?
Yes, if she is, Piyush, good question. If she has swelling of feet and eyes, definitely there's a likelihood that she's got diabetic kidney disease. You will need to check the basic tests, a complete urine examination and a urine microalbumin and a serum creatinine. That will tell us whether she has early diabetic kidney disease or not. And we can, if it's early, we can set it right. If it is not early, we can at least limit the damage. So these 3 tests need to be done as soon as possible: a creatinine, a complete urine examination, and urine microalbumin.
Yeah, thank you, Doc. Dr. Swasni has suggested few things, the technical things, which I will, right now, you have also seen it. It's a good thing suggestion.
Yes.
But as a diabetic challenge, I will not go into that. So let it be easy for the participants. Okay. My second question is from Rima. My brother has low blood pressure and diabetes. He takes electrolytes regularly. He suffers frequent urination. Is it due to diabetes or he is developing a kidney disease? It's a very good question, actually.
Yes, Rima. So yeah, good question. Now, remember, there is something called diabetic autonomic neuropathy. So when you have diabetes, though we expect the diabetic patients to have high blood pressure, but some of them, because of some damage to the nervous system, the blood pressures are on the lower side. So this is a very tricky situation, because if you have diabetic kidney disease, everybody talks about low blood pressure, making a BP as low as possible. And the medication that we use to reduce the protein in diabetic kidney disease can drop the blood pressure further. So it's important that you need to just confirm whether he has got an autonomic neuropathy or not. And there are some tests that we can do. But otherwise, do the basic testing, see if he has got any protein. Now, Finrenone, which has recently been approved, it does not reduce the blood pressure so much as compared to the other medications. So that could be an option for your brother. Usually, diabetic autonomic neuropathy comes after the age of 40 or 50. So I'm not sure how old your brother is, but definitely get a neurologist to check and find out why the blood pressures are so low, and figure that out. But I think you will need to see a nephrologist as well, so that we can fine tune the treatment. This is definitely a tricky situation.
Yeah, true. Mr. Sarfraj is asking, my father is diabetic. He also takes medicine for blood pressure. Will it increase the risk of kidney disease?
Oh, yes, Sarfraz, it depends on what the blood pressure medicine is, and it depends on what the creatinine is. For example, if the creatinine is more than 3 and you use these ARBs or ARs or ACE inhibitors like
Yes.
either cardase or telmisartan, that can worsen the creatinine. So you need to know, one, what the creatinine value is. If the creatinine is okay, not too high, then any blood pressure medicine is okay. But ideally, an ACE inhibitor or ARB, for example, telmisartan, olmesartan, or cardase or ramipril. So it's important to know that. But blood pressure medicines per se increasing the risk of kidney disease, no. In fact, you would want to use blood pressure medications to reduce the risk of kidney disease by keeping the blood pressure under control.
Yeah, true, Doc. There is one interesting question. See, every participant, whether they are themselves suffering from diabetes or have some chronic disease or their family members, they are worried about everyone. So, KM Reddy has asked, Doc, he or she, I don't know, Ravi, my mother, Doc, he asking you. My mother has a kidney issues and recently undergone treatment on dialysis. Her urine output is increased from 100 ml to 800 ml in a month's time. But from last 1 week, it came down again to between 100 to 200 ml. Can you suggest on this?
Yes, so this looks like there is been a initial partial improvement in the kidney disease, Mr. Reddy, for your mother. Now, it also depends on how much fluid is being removed during dialysis. If a lot of fluid is being removed during dialysis, then the urine output would drop. So one way to understand this is to check her weight and look if she has got swelling. If she has swelling and her weight is not reducing too much after dialysis, then more fluid needs to be removed. Whereas if she doesn't have swelling and she's not gaining too much weight during that in between two dialysis sessions, they do not remove too much fluid. That itself might improve the urine output. So this is the key to see whether she is gaining weight and if she has swelling. If she has swelling, remove more fluid on dialysis. If she does not have swelling, remove less fluid on dialysis, and hopefully the urine output will pick up.
True. I received one message in the morning because the participant is from Abu Dhabi and she was not able to attend the program. So she has asked one question. She is 32 years old. She is pre-diabetic and she was tested positive for protein in the urine. What worry is it related to kidney disease? And she is
If she
pre-diabetic.
If she is not a diabetic or a pre-diabetic, and if she has protein in the urine, there is another cause for the protein. This is definitely some kind of kidney disease. And apart from diabetic kidney disease, there are a lot of other reasons for protein in the urine. Sometimes just excessive physical activity can do that. Less fluid intake can cause protein in the urine. Infections in the urine can cause protein in the urine. So, and there are some other disorders like nephrotic syndromes where you can have protein in the urine. So she needs to be identified as somebody who's got kidney disease, and we need to figure out the cause of the protein in the urine. It is not diabetic kidney disease, it's something else. For that, she might even need to undergo a kidney biopsy if the protein levels are very high. So
Yeah.
see a nephrologist and find out the cause of the protein in the urine. It could be just something simple as poor physical or excessive physical activity, poor fluid intake, or urine infection, or it could be something more sinister. And the nephrologist is the best person to decide what it is. And if a kidney biopsy is required, please go ahead and do it.
Yeah, true. Actually, her father is insulin dependent diabetic patient for so many years, and that was she was worried about. Okay, that answer suits, and she must be consulting a specialist.
Yes.
Rima has asked what kind of exercise you recommend for people on dialysis. It's a very tricky question, actually.
Yes. Now I have a few young dialysis patients who do all kinds of exercise during while they are on dialysis. And the one I can remember is one gentleman from the UAE itself. He is 45 years old. He's on dialysis for the last 5 years, and he does everything. He does weights, he does cycling, cardio, crunches, warm-ups, everything. And it's your body which will tell you how much exercise you can do. So go listen to your body. If your body, you start doing the exercise, if you find that it's too much, you're getting breathless or you're getting joint pains, then reduce the exercise. But there is no limit. You can do any amount of exercise. The things that will limit you, apart from the kidney disease, if you put that aside, is low hemoglobin, high blood pressure, and low calcium and vitamin D. If you have low calcium, vitamin D, you will have pains. If you have low hemoglobin, you will not be able to do, you will get breathless soon. And so if you have high blood pressure, again, it will cause breathlessness and discomfort. So keep all these things under control. You can improve the hemoglobin by injections. You can control the blood pressure by medications. You can replace vitamin D and calcium by supplements. So if you can do all that, put everything into place, there is no limit to the exercise that you can do. It's all in the mind.
Yeah, all blanket covered answer. It's a very good answer. Like Professor said, all participants are very much interested in listening you. And one, Mr. Peter has shown his gratitude towards you. He's very much thankful to you. That's a great thing. Doc, it shows your repo in the patients. Yeah, there are no more questions, but what I will take as a take on message, my question as such, for a diabetic patient on a regular basis, or irrespective of any kidney or chronic disease, what do you suggest? What a diabetic patient should regularly look into?
Blood sugar control, I've already said the targets, Dr. Wilgu. Blood sugar fasting below 120, post meal below 160, and HbA1c below 7. Keep the BP below 130 by 80. Do regular exercise. Make lifestyle modifications. Be careful about your diet. Reduce salt. See, apart from sugar alone, there are a lot of other things that can impact on your life and your lifestyle. So things like oils, fats, salt, junk food, all these things should be minimized. I'm not saying that you should live like a hermit and not eat anything at all, but do it judiciously. And if you do go overboard sometime, compensate with another meal. So if you eaten a lot of sweet at breakfast time, compensate for the next 2 days and just get off the sweet. And this concept of cheat days is not a concept. I don't believe in this concept of cheat days. I mean, who are you cheating? You're cheating yourself. So
Yes, sir.
discipline is crucial. Discipline is important. Just make sure you do everything the same way every day. As far as possible, try and eat the same amount every day. And that will take you a long way towards keeping lifestyle diseases at bay. Apart from diabetes, there are so many other lifestyle diseases. You can keep all those away by this discipline. That's all. Watching what you eat. And sometimes I would even suggest watch yourself eating what you eat. So you stand in front of the mirror and you see what you're eating, and then immediately you'll be demotivated. I don't think I can eat this. So watch what you eat carefully. Do have a regular exercise, and exercise needs to be done every day. One famous personality once said, "My day has only 22 hours. Only 22 hours. It doesn't have 24 hours. Only 22 hours. 2 hours are for exercise." So, I mean, I wouldn't go for 2 hours for exercise, but at least 1 hour of exercise per day. Exercise, diet control, keeping your blood sugars, your blood pressures under control, and regular checkups. Make sure you get yourself checked at least once a year by either a physician or since you're a diabetic and don't have diabetic kidney disease, make sure your physician checks you on a regular basis. And these tests are mandatory every year: a serum creatinine, serum electrolytes, blood sugar, a complete urine examination, and an HbA1c with urine microalbumin. These need to be done every year.
Yeah, true. That was a complete answer, Doc. Thank you so much. Professor, over to you. I don't have more questions.
Dr. Ravi, you are a doctor, of course, but you should really be a philosopher. Your answers were so profound in so many ways. And I'll give you just one or two examples of what you have said. For example, you said it could be simple or it could be complicated. It is for your doctor to decide. And I think that is very, very true on the one hand. And on the other hand, in answer to another question, and I must tell you, Dr. Ravi, I have spent perhaps more than 50 or 55 years in the field of physical activity and exercise. But this answer was new, and I am grateful for my learning. Thank you so much. The question was on dialysis, and your answer to that question was, listen to your body. Now, what could be more profound than that? You know, people like us who are not medical professionals would always tell our clients, please consult your doctor. And here is a doctor who says, consult your body. I think that is profound. I think that is profound. I recall seeing beeping up on the screen a remark or a message from one of the participants who said, Dr. Ravi, you are a blessing to many. And that is what came up on the screen. And I think that is the final tribute. Thank you so much, Dr. Ravi. So deeply grateful for your friendship and your knowledge. Thank you so much.
Thank you.
Thank you so much. Friends, a fitting finale to our 10 series on DiaBeat and diabetes. In this instance, nephrology. I'd like to thank Dr. Ravi, and I can never say thank you enough. I'd like to thank Dr. Wilku. Clever questions, always trying to get his speaker bowled out by a googly, but not succeeding in this instance at all. So that's good. I'd like to thank my team on the back end, the Arabian Wellness and RAC Hospital team, and the IT team. Now, I don't quite know what Doc Suhasini may have mentioned over there about the technical glitches, and I'm sure they were there. We will take care of them the next time Doc Suhasini. But on screen, hello, and how are you? Good. And thank you to my audience. You've been kind and you have stayed with us for this webinar for the last 10 weeks. Thank you so much. And also thank you for participating in this 3-month challenge. There are 5,000 of you out there who we are hoping to support. Remember, your final day is on November 14th when we do the final testing, and we'd love to see some great results. With that, and that closes our season in webinars today. Thank Dr. Ravi, Dr. Wilku, and all my listeners. Thank you so much. God bless you and have a great day.